Yeah, we can start.
Okay, good evening once again. Welcome to AfroDX, and I have a very good case today that I think we'll learn a lot from David. Um, so this was a 47-year-old female whom I saw on the outpatient clinic who complained of tongue and neck swellings.
Okay, interesting right from the beginning, and I think this is going to be tough for me. I'm not sure what to make out of this. A 47 years old female presenting with tongue and neck swellings. Uh, so this, I mean, I'm not sure if at this point I get it clearly what is going on, but I think so. My quick thoughts are what exactly is causing the swellings. Of course, I'll need. I think because I do not have many things in mind at this point. The first thing I'm waiting for is clarification to know the pattern of this swelling that we are talking about. But then a number of things are to be considered. Of course, the time course will be important, but so if the swelling of the tongue, for example, I think I'll just try and throw out a few differentials at this point. If it's of a short period of time, someone can have a swelling because of edema, for example, as in angioedema. So someone will present with swelling, but then what I'm thinking of is does angioedema, of course, angioedema can present with swelling of the tongue, the lips. Uh, you can have the edema even in the larynx, like I think we discussed the case here uh, just a few weeks ago of anaphylaxis. But then at this point, I'm trying to think that seems a little far-fetched for me, and this could be a limitation in my knowledge. Does that present with neck swellings? And of course, when we talk of neck swellings, are we talking of a uniform swelling due to edema, for example? Are we talking of lymph nodes, for example? So I think I have questions. So edema could be a possibility, which of course is partly explained. The edema could be due to angioedema purely, which is not inflammation, but it's a vasoactive reaction. But you can also have swelling as a result of some inflammatory conditions. So I cannot quickly think of any infection that could lead to uniform swelling of the tongue or swelling of the tongue for that matter. I think dental surgeons are more of experts in this area. But then any other inflammation that could lead to swelling of the tongue, I think I'm very limited in differentials, but the history will help me clarify a number of issues and see if I can make any progress. So let's proceed to the HPI.
Yeah, thank you very much for a good start. And so this SPI, 2 years ago, she noticed a swelling on the right side of the neck. The swelling was painless, gradually increasing in size. And after a few months from there, she also noticed other new swellings below the jaw, which were also painless and gradually increasing in size. This was followed by another painless swelling on the left side of the neck after several months. And 7 months ago, she noticed a swelling on the left lateral border of the tongue. The swelling is painless, it is non itchy, and also gradually increasing in size. She said it is associated with fatigue, and she reports a 7 kg weight loss over the past 2 years, although she didn't change level of activity or food intake. But she denied cough, shortness of breath, fever, or night sweat. There was no history of headache, jaw pain, bleeding from any side, abdominal pain, or diarrhea. The nervous system, she reported intermittent nasal symptoms, which were obstruction, anosmia, postnasal drip, but she didn't have any nosebleeds. Past medical history is non-contributory. meds. He was on decongestant nasal sprays and desloratadine. Family social history. She's married. She's 4 kids. She's a homemaker, and she doesn't drink or smoke. I think you can discuss this.
Very interesting. So, as I said earlier, yeah, I wanted this clarification because oh, I think the time cause and then the pattern makes a huge difference. So the swellings that we are talking about, it seems that we are not talking of uniform swelling of the neck as well as the tongue for that matter. It's discrete swellings that started at different time points, and these swellings started 2 years ago. So basically, we are talking of something chronic here. So she starts with a swelling on the right side of the neck, and it's painless, gradually increasing in size. And then a few months later, she notes new swellings again below the jaw, which are also painless and gradually increasing in size. These swellings, what are they? So when we think of when we consider the swellings on the neck, which can be this much discrete, so a reflex is to talk about lymph nodes, and I think that could be a huge possibility in this patient, that the swellings that we are talking about are lymph nodes, because otherwise, of course, there are other things. I mean, a swelling can arise out of anything. So, and when we are talking of neck swellings, and these seem to be on the sides. So, when you are talking of swellings on the neck, it could be cysts, but then cysts are something, I think that maybe not very much at this age. And then if you are talking of swellings that are rising from the skin and subcutaneous tissue, because yes, you could have lipomas, but then, I mean, this doesn't sound like anything like lipomas, for example. So, considering the structures that we have, or considering the anatomy of the neck from the outside, that we have the skin and subcutaneous tissue, you also have some muscles in the neck, you have some lymph nodes in there, you have fascia, and then you have blood vessels and nerves which are deep within. So, most likely the swellings that we are talking about are lymph nodes, but we should also be open to other possibilities. But I'm convinced that they are likely lymph nodes. But I think, to be more objective, I'll wait for physical examination in order to conclude whether the swelling are lymph node swellings. We are talking of lymphadenopathy, or if it's any other swelling which I find hard to make sense of. And then she presents with the swelling on the left lateral border of the tongue, and it's painless, non-itchy, gradually increasing in size. Now, this is what brings confusion to me. What exactly are we talking about? A swelling arising out of the tongue and on the lateral border of the tongue. So anything that we are talking about, I mean, at 2 years, and then the tongue swelling is present for 7 months, is not uniform. So whatever I talked about regarding angioedema or anything of that sort is out of the picture. So we are talking of discrete swellings, which are more of chronic issues, because we are talking about a 2 years history for the neck swellings, and then 7 months for the tongue swelling. And then there are some symptoms, or one predominant symptom, which is a constitutional symptom, and that is weight loss. So no fevers, no night sweats, but there is a significant and intentional weight loss over the 2 years. And and there is a non-specific symptom, which is fatigue. So when I think of these swellings and then tying it together with the weight loss, so weight loss itself, I think, will not be adequate enough to say there's inflammation going on, but it's an equivalent. It's an equivalent. So when we talk of weight loss, Joseph has already told us that this patient has not changed intake of physical activity for that matter, which could lead to relative changes in input output, which decides whether someone gains or loses weight. So most likely, this weight that we are talking about is not due to anorexia, because otherwise we would have heard about changes in intake, which would be a possible explanation for the weight loss. We have not heard of any symptoms. Joseph has told us no abdominal pain, no diarrhea. So malabsorption is not likely for this patient, because if we are talking of weight loss, it's either someone's intake is low, which is not the case for this patient, or they are taking inadequately, but then digestion and absorption are not taking place adequately. So, for example, when someone has malabsorption syndrome, not the case with this patient because there is no diarrhea. So, when there is malabsorption, commonly we see diarrhea. There is no diarrhea in this patient. So, probably absorption is taking place adequately, intake is adequate, and therefore, a huge possibility here is that this patient's metabolic rate is high. And that is an explanation for the weight loss. And therefore, if that is the case, we should consider inflammatory conditions. And these inflammatory conditions include infections, which for this patient, when you talk of an infection which could play out this long, tuberculosis is one of those. But then we are not hearing any fevers or night sweats. But absence of those is not adequate to say tuberculosis is not a possibility, because again, I'm assuming this patient is from our setting, which is endemic for tuberculosis, and therefore TB should be a consideration, or infections in general. And then autoimmunity, we have not heard of other manifestations which are pointing us in the direction of autoimmune disease, but we should consider that. And then malignancies. So malignancies, for example, for this patient, because it started with neck swellings, which could be lymph nodes, and therefore a lymphoma is one of the things that we need to consider. And then, of course, if we are talking, because yes, there are malignancies that are rising out of the tongue, but what we would expect is that initially the patient would present with a tongue swelling, and then the lymph node swellings, and of course, the neck swellings being painless and gradually increasing in size. I think that is very concerning for neoplasms. So I think I'm also entertaining neoplasms here, but what exactly is the primary? Are we talking about neoplasms that are coming out of the lymph nodes themselves, lymphoma being on top of the list, or are we talking of neoplasms which are rising out of other structures and then spreading to the lymph nodes? Not yet sure of that. So I think I'm considering those. And then on top of that, we should also consider conditions which are infiltrating, which could be or could not be inflammatory conditions, but infiltrative conditions, which I think as the case plays out, I'll see if they make sense for this patient. So regarding the history, I think that's what I have. Can I see review of systems? Yeah, so there are nasal symptoms, intermittent nasal symptoms. So are they related to this? So when I put together neck swellings and then intermittent nasal symptoms, which are obstruction, anosmia, postnasal drip, so there is rhinosinusitis going on in this patient. So how do you tie together uh, a 2 years history of neck swellings, and then 7 months history of a unilateral tongue swelling in a 47 years old female who is also having significant unintentional weight loss and fatigue with intermittent nasal symptoms. So something that comes to mind, although again not the whole picture based on the textbook presentation that I know. So when I discuss vasculitides, for example, ANCA-associated vasculitides like GPA, EGPA, I know they do present with nasal symptoms, but then the other syndrome is a pulmonary renal syndrome, which could be difficult in breathing, plus or minus cough and hemoptysis, and then hematuria, which can either be macroscopic or microscopic. So rhinosinusitis can be part of a systemic syndrome. So for this particular case, I think I'm still at crossroads whether it is connected to the other presentation or not. But I'll see if that makes sense, especially when it comes to physical examination and maybe on investigations. So as I remember, the medical history is unremarkable. Family social history, I didn't pick anything that is of note. And so for medications, this patient is on decongestants because of the recurrent rhinosinusitis, which I still haven't found a place to fit it perfectly. So let's go to physical exam in order to see if I can make any progress based on that.
Sure. That's a good progress. General exam. Patient was alert and oriented. She was febrile. She had conjunctival pallor. She didn't have jaundice, and there was no oral lymphedema. Lymph node exams on the submandibular region, she had multiple, smooth, non-tender, non-matted mobile lymph nodes. On the right cervical region, she had single, mobile, smooth, non-tender lymph nodes. And on the left cervical region, she had multiple, mobile, non-tender, non-matted lymph nodes. On the left axilla, she had a single, mobile, non-tender lymph node. ENT exam, there was a nodular lesion on the nasal vestibule, and the vitals were within normal limits. So here's the picture of the tongue lesion that you can appreciate. This one. I noticed a rash when I examined the skin of this patient. I don't know if you can see it clearly, but when I palpated this rash, it was erythematous tender nodules. It wasn't plaque as it seems here. It was a nodule fixed down there, and it was located on the right shin. Systemic exam, abdomen, chest, cardio, neuro, musculoskeletal, we're all unremarkable.
Okay, so as I suspected earlier, though I should say that is partly because I have a limitation in a list of differentials I could think of when talking of multiple neck swellings. So so we are basically talking about lymphadenopathy, and these lymph nodes are multiple. They are not matted. They are mobile. They are non-tender, and so submandibular and then cervical as well as axillary lymphadenopathy, plus a nodular lesion on the nasal vestibule, and then the lesion on the tongue. Can I see that image? And if you can help me describe what you saw, because I'm trying to zoom it. I'm trying to zoom it. Is the color of the lesion different from the rest of the tongue?
No, it is not different. It's
So
like
it's the same color
yes,
as the rest of the tongue.
yes.
Okay. Any other features? Especially, did you try to uh, did it have any ulceration, for example? Was there any
Uh,
tenderness?
yeah, so it wasn't tender. It had irregular border. It I could say it's a nodule. It was small. It has a little cuts you seeing there up there. Someone took a biopsy recently. That's why it looks like that. But so far it's a nodule like 0.5 centimeter.
Okay. So when it comes to the tongue, and I think I think this is because probably we rely very much on dental surgeons to deal with the oral cavity as well as the tongue. So I do not have many differentials, but I'm wondering because uh, the other things that the other neck swellings that we are talking about, we've concluded that they are lymph nodes, but the nodule that we are dealing with on the tongue, a, a nodular lesion on the left lateral border of the tongue, about 0.5 centimeters. What is going on? Of course, with with I mean, I one of the possibilities that I'll consider is that it's probably a neoplasm, and of course, if it's a neoplasm, it can be, as I talked about earlier, that you also have infiltrative conditions that can also involve the tongue. So for example, because if I use the lymph nodes as the pivotal point to discuss what could be going on, lymphadenopathy in multiple areas, as we saw, submandibular, axillary, as well as cervical lymphadenopathy, and then with this tongue lesion, and then with the nodular lesion on the nasal vestibule, and with what could probably be erythema nodosum on the I do not remember whether it was the right or left shin, because Joseph told us that the lesions, that is the right shin, so that the lesions are erythematous, they are tender. So I interpret that to be erythema nodosum. So you have a patient with multiple lymph nodes on the neck, so cervical, submandibular, axillary lymphadenopathy, and then you have nodular lesions on the tongue and the nasal cavity, and then you have erythema nodosum. The patient is having a recurrent rhinosinusitis. So what could be going on? As I said earlier, I think I'll consider infectious conditions. Tuberculosis, very much conflicted in this patient, because first, with these multiple lymph nodes, and for tuberculosis commonly the lymph nodes are matted, and with this long duration, at least uh, based on a few cases that I've seen of TB adenitis, so commonly the lymph nodes are huge, matted, and 2 years duration, probably some of them would have formed the sinuses, commonly for tuberculosis, and probably uh, constitutional symptoms, especially fevers and night sweats, would have been very prominent in this patient. And I struggle to find a way to link, although erythema nodosum can come with anything, including infections like tuberculosis, but especially with the tongue lesion and the lesion on the nasal cavity, on the nasal vestibule, I find it hard to connect those with respect to tuberculosis. But when it comes to autoimmune and other inflammatory conditions, I think there are some infiltrative conditions that I can think about. So, for example, sarcoid. Sarcoid, can present with lymphadenopathy, can present with, I do not remember correctly about erythema nodosum, but plus or minus. And about the tongue lesion, I think possible. And another thing is amyloidosis, especially for amyloidosis, of course, a swelling on the tongue, very, very possible, but then maybe, so macroglossia is commonly the presentation when you are talking about amyloid involving infiltration in the tongue. And then another thing is like, so for example, IgG4 related disease, which is another tumefactive condition, but the tumor-like lesions are not limited to the lymph nodes, the tongue, and the nasal cavity, but they could also present on the skin. So, and I find it hard to fit that in this patient. So regarding autoimmune conditions, I think sarcoid, which is autoimmune or slash inflammatory condition, and then amyloid as an infiltrative condition, I think those ones are better fitting in this patient regarding the lymph nodes and then the lesion on the tongue, plus or minus the nasal cavity, and then the erythema nodosum. And then, of course, as I said, I think lymphoma and other malignant neoplasms, including a primary in the tongue and then spreading to the lymph nodes. But then, so after 2 years of presentation, I think a malignant neoplasm is far-fetched for this patient, because especially for I've seen, or at least observed from a distance, a case of cancer involving the tongue, which spreads very quickly downwards into the pharynx, and commonly for malignant neoplasms, we expect the lymph nodes at this point, maybe they would have been fixed and not mobile as we see in this patient. But we also have to entertain a possibility of malignancies in this patient. So I think regarding differentials are still very wide, and I have not made much progress, but I think I'm mostly limiting myself to infections, tuberculosis, which does not fit perfectly, but then autoimmune slash inflammatory conditions, I have a few considerations, and then malignancies, including uh, lymphoma as a primary and a tongue neoplasm. So let's proceed to investigations, so I can see if I can make any progress.
Yeah, that's a
Tough case.
yeah, sure. Tough case indeed, because that's a superb dissection of the case, by the way. So let's see. These are the labs. She had a white count of 3.6, slightly low from the lower normal 4. And differential, the absolute neutrophil count was 1.86, also slightly reduced. She had a moderate anemia of 7.4 with an MCV of 54, also reduced. Hematocrit was 26.8%, reduced. MCHC also reduced 27.5. The RDW was high at 65.6, but platelets were normal. The chemistry, liver and renal were normal. RBG, she had HIV negative. ESR was 30, and RPR was also negative. So she did also peripheral smear, which showed hypochromic microcytic RBCs with small normocytic population and pencil-shaped cells. The white count had mild neutropenia, platelets were normal, and the retic were raised at 5.5%.
Yeah, so with the CBC, a bicytopenia, low white cell count, including absolute neutrophil count slightly low, and then hemoglobin at 7.4, microcytic hypochromic, normal platelet count. The chemistries are normal. So I talked about a possibility, for example, of about sarcoid and amyloid. So these are multi-systemic, and commonly even the kidneys are involved, and the liver also could be involved. And of course, another thing is that with the infiltrative conditions, hepatosplenomegaly is a common presentation, not 100%. We have not seen that in this patient. So liver as well as renal chemistries are normal, and then HIV is negative, very important, of course. Um, and then ESR, so ESR is the cutoff still 25, is the cutoff 25 for the particular lab that took these investigations. Joseph,
Yeah, so the cutoff is, I think, 20.
20. Okay, so elevated ESR, and then RPR negative. Yeah, so syphilis, a great masquerade. I mean, it can come with so many things. So RPR negative, but then elevated ESR, which is pointing us in the direction of inflammation. Um, HIV negative, very important because HIV can present with persistent generalized lymphadenopathy, very important. So HIV being negative, and of course the lymphadenopathy has been playing out for 2 years. So HIV being negative is relieving, so very important to be considered. So bicytopenia with what seems to be a picture of iron deficiency anemia. Let's see the peripheral smear. So hypochromic microcytic, small nomocytic population, and then pencil-shaped cells. Okay, so these are pencil-shaped cells. I'm not sure what to make out of it. I know there are many kinds of abnormal cells that you see. So I'm not sure if this can also be seen in conditions. I have not talked about some conditions like so. Of course, we need to entertain a possibility that something could be going on in the bone marrow as well as the lymph nodes, especially when we are talking about the bone marrow. Not very likely, because the reticulocyte count seems to be seems to be see the reticulocyte count is elevated. Now I because this is the percentage, it's way above what you expect for normal. So if we correct this, it's likely that the bone marrow is reacting appropriately. So um, what exactly is going on with a bicytopenia in the labs? The kidneys as well as the liver seem to be spared, at least from the renal function test as well as liver enzymes. Maybe there is no vet inflammation that is going on in the liver or renal dysfunction at this point in time. But there is a bicytopenia. So what is going on? And the reticulocyte count is elevated, which means the bone marrow is responding. So when you are talking about anemia now, let's see if this anemia can help us make progress. So basically, when you talk of anemia, we consider it's either a problem with the factory, which is the bone marrow itself, and that can happen with infiltration from neoplasms and from infiltrative conditions like the ones I've talked about, sarcoid as well as amyloid, which can present abnormally shaped cells. I'm not sure if pencil-shaped cells are part of this. And you also have other conditions that we need to consider although of course I would need to go back and peruse in order to see the presentation fits, like myelodysplastic syndromes, uh, myelofibrosis, and of course another thing is when you see lymphadenopathy and some constitutional symptoms including weight loss. Kestoman disease is another thing. So Kestoman disease, basically you have a population of cells that abnormal cells that are populating the lymph nodes, and you end up with lymphadenopathy. And this, of course, can be uh, limited to the lymph nodes, and it can be multicentric, involving in even the liver and the spleen, which seem to be spared in this patient. So uh, I find a hard time to say that a primary problem could be in the bone marrow, because the reticulocyte count is elevated, and as you have seen, the red cell distribution width was also high, which means you have red blood cells at different stages of maturation, which is typical of the bone marrow reacting to a peripheral process. And so this peripheral process could be uh, that you have increased the peripheral destruction of red blood cells, which we have not seen in the chemistries. Can I see, Joseph, if you included bilirubin direct and total there? Okay, so there was no total and direct bilirubin. I think markers of hemolysis are also important in this patient, including bilirubin direct total, as well as LDH. I know others we do not have in our setting, like haptoglobin and others. So we need to see there is a peripheral process going on, although iron deficiency is also a possibility in this patient, and therefore part of further evaluation for this patient, we will need to send iron studies in order to see if iron deficiency is contributing, which can be localized to the bone marrow, but then a problem with maturation because of deficiency of the raw materials, especially iron, in this patient. So do you have any other labs so I can see if I can make any progress? Because I see time is going and I'm not making further progress. Do you have any other labs or other investigations?
No other lab, so we proceed. That's a good interpretation of the peripheral smear. Is the same as the hematologist also suggested. This looks like iron deficiency anemia. So let's proceed. So imaging, the abdominal ultrasound and chest X-ray were normal. She did a contrasted CT head and neck, which showed an enhancement on the focal area of irregularity on the left anterior and posterior tongue. There was non-enhancing focal protrusion on the right tongue base. There was bilateral lymphadenopathy in submental, submandibular, and along internal jugular chain. Also, there was the visualized portion of the chest revealed multiple metastatic nodes bilaterally. I think because of time, let me proceed and give you another record. So the radiologists advised we do a biopsy of these lymph node, and so the next record will be the biopsy. So this was the biopsy of the tongue lesion, which showed thickened mucosa with multiple granulomas extending to the skeletal muscle. The granulomas were composed of epithelioid cells, multinucleated giant cells, and rim of lymphocytes. There was no necrosis seen. There was no evidence of malignancy. The pathological diagnosis was chronic granulomatous inflammation, and the pathologist recommended to do ZN and PAS staining, which were done a week later, and they were both negative. So I think you can discuss from the CT to the biopsy.
Yeah, so ultrasound and chest X-ray normal, of course limited, because for some of the differentials that I've mentioned, like sarcoid, for example, we so commonly what we we read from the textbooks is that you see lymphadenopathy. Yeah, can present with hilar lymphadenopathy. So the chest X-ray didn't pick that, and then ultrasound is normal, which means no lesions were picked from. I believe that was abdominal pelvic ultrasound. So the liver, the spleen, nothing picked, and then no report of para-aortic lymphadenopathy, for example. But then CT tells us that there are irregularities on the tongue, and then so this tongue, because enhancement on focal area of irregularity of the left anterior and posterior tongue, non-enhancing focal protrusion on the right tongue base, and then the lymphadenopathy that I think we had already talked about, and then multiple metastatic nodes bilateral. Can I see the biopsy? So what I picked from the biopsy is that malignancy has been excluded from the sample that was taken from the tongue, but what is seen is chronic granulomatous inflammation, and Zn staining is negative. So tuberculosis. So with this, so commonly with the granulomas, I think from biopsy specimens, I think the yield is quite good. Although I'm not sure with the yield in terms of numbers, but I think it's relatively good. So are we dealing with something metastatic and we do not know the primary, or are we dealing with something else? My guess is, of course, we could also maybe benefit from samples from the lymph nodes in order to see if it's a primary from anywhere else that could be picked. But I'm suspecting that it's a granulomatous disease, but not malignancy. And this is where we have possibilities like sarcoid, which I've already talked about. So sarcoid can explain the suspected metastatic nodes in the lung, in the chest. It can explain the tongue lesions that are seen because of infiltration. Sarcoid can do that. And then erythema nodosum is associated with many inflammatory conditions, including sarcoid itself, including inflammatory bowel disease, and many autoimmune disease that you can think about can be associated with erythema nodosum. So I think sarcoid is part of my differentials. And then amyloidosis, which is another infiltrative condition. But then maybe does it form granulomas? Does it form granulomas as does sarcoidosis and tuberculosis? That is a question that I have. I think that I do not have an answer to at this point. So sarcoidosis, amyloidosis, and then because of the granulomas, I think tuberculosis should be part of our differentials, but then Zn staining has been done. Zn staining has been done in tissue. So I think I would need to go and check about the test characteristics in order to see if I can confidently rule out tuberculosis at this point. But I think even without that, far-fetched in my list of differentials. So still complex, haven't made much progress, but let me try and represent this problem one last time before I commit to a number of differentials, because I think I'm not in a position to mention just one. So we've been discussing a 47 years old female who presented with a 2 years history of evolving neck lymphadenopathy. because the swellings that we've seen, we've concluded that they are it's lymphadenopathy, cervical, submandibular, as well as axillary, and then others were picked on imaging. And then she also presented with a swelling on the left lateral tongue, as well as a nasal nodule also. She has significant unintentional weight loss, recurrent rhinosinusitis, as well as fatigue, but she does not report fevers, night sweats, or any GI symptoms. On examination, neck lymphadenopathy is confirmed, and then she's also having erythema nodosum. She is pale, and then when it comes to investigation, the CBC is significant for bicytopenia with a hypochromic microcytic picture, but normal platelet count, and then ESR is elevated, renal as well as liver chemistries are normal, and then a peripheral smear also reveals a hypochromic microcytic anemia, suspicious of iron deficiency anemia, but the reticulocyte count is elevated. So what could be going on in this patient? So it's involving more than one system. So we've seen the lymph nodes. We've seen that the chest is involved on imaging. The tongue is involved. And then hematologically, there's anemia and leukopenia. But the bone marrow seems to be responsive, seems to be reactive. And then there is inflammation. And then, of course, integumentary also, there is erythema nodosum. So I am thinking that the diagnosis is coming out of the bucket of infections, autoimmune, slash inflammatory, and malignancy. Regarding infections, tuberculosis low on the list because biopsy, Zn staining that was done did not yield anything. So among infections, TB low on the list. And then autoimmune slash inflammatory, sarcoid is a possibility. Amyloidosis as an infiltrative condition, although I will need to go and check on the characteristics of amyloid, how it would present. So amyloidosis, I think, is a consideration in this patient. Lymphoma. So I think lymphoma is worth considering in this patient, although it would be hard to explain if the neoplasm is in the lymph nodes, how did it go to the tongue? So that is why I find it hard to explain. So, and then am I missing something with iron deficiency anemia and these swellings? Is there something else that is going on? Not exactly sure. So those are, I think I have on top of my list, I have sarcoid, I have amyloidosis, and then among neoplastic conditions, I think I'll still, although far-fetched, I'll keep a lymphoma as part of differentials, but a neoplasm of an undetermined primary at this point would be unlikely because the tongue nodule did not report any features of inflammation. And then I think maybe in order to just make sure that I narrow down, I would be well served to consider granulomatous conditions. So among infections, I've talked about tuberculosis. Among autoimmune conditions, I've talked about sarcoid. So I think there are some other granulomatous conditions that I am missing. So non-tuberculous mycobacterial infections being one of them, although Zn staining would be revealing for those because they also acid-fast bacilli. So not likely. Yeah, so I think those are what I have, and for the sake of time, I think I haven't been able to consider everything to completion, and I am limited in differentials, but sarcoid, amyloid, and then TB on the list, as well as lymphoma and other neoplasms. I think I am not confident to commit to one particular diagnosis. So Joseph, back to you to take us home.
Yeah, thank you very much. You're so intelligent, man. This is a very hard case, but well dissected, and it's very, very correct. I think if someone is listening to you, they've learned a ton of things that I think I don't even to put teaching points here. Yeah, so let's go to the case resolution. So based on the peripheral smear, anemia was deemed undeficient and unrelated to the rest of the findings. And yes, when I saw her, she was given iron and she responded. So her retic might fool you to think there is ongoing hemolysis, but always remember to calculate the reticulocyte production index whenever you see anemia, and as it corrects for the degree of anemia, because you ask yourself, if she didn't have anemia, what would be the retic? Would it be also high or low? And the formula there is you take reticulocytes percent that is given, you times hematocrit divided by 45. The answer to that divided by 2. If you do this, so this case comes 1.6. And if the RPI is less than 2, the marrow is underproducing. And if it's above 2, the marrow is adequate producing. So in this case, it's 1.6. It was underproducing in keeping with iron deficiency. So that's why there is even no markers of hemolysis. There was no hemolysis in this case. So the tongue nodules followed generalized lymphadenopathy after a year. So the explanation should be like, the nodule should be explained by a diagnosis which explains the generalized lymphadenopathy, and not the reverse, because it's not that the tongue lesion started and then the nodes followed, the opposite. But you know, the differential diagnosis of generalized lymphadenopathy is like tiring, so wide. Like you cannot have this, but at least you have these groups. So at the end of the day, you need to have a biopsy, in this case, it showed granulomas. And so you narrow it down, you consider the differential diagnosis to granulomatous diseases on histopathology. And David, very good. You got most of them correct, and you divide them. I didn't even know that lymphoma can have granuloma on histopathology sometime. But we have infections of particular importance here is the mycobacteria because of the epidemiology. These others like Bartonella and Brucella and Coxiella, tularemia, they have other symptoms this patient did have. And fungal, you have to be immunocompromised to have a disseminated fungal disease like that. This patient was immunocompetent. Schistosomiasis wouldn't present like that. Leishmania, less likely. On the part of autoimmunity, it couldn't be vasculitis. There was nothing that shows this patient has vasculitis. But others, like sarcoid, as David is saying, is very, very possible. Crohn's, PBC, no symptoms. So at least 2 here, that maybe this patient is having mycobacteria or sarcoidosis. So that was the last. And this is very important because, you have to get this right. Sarcoid is treated by chronic immunosuppressive drugs. And if you give that to a patient with TB, if the TB is just localized in the lymph nodes, it will be disseminated. The patient might die of TB. So you have to get this right. And so if you consider the epidemiology around here in Tanzania, you think TB should be higher than sarcoid. But look at the tempo of the disease. A 2 years disease that is indolent like this, just slowly coming up, and then all of a sudden the patient shows up because of a nodule on the tongue. Sarcoid is more indolent than TB. A 2 years TB will be aggressive. And as you see in the teaching point, some patient of sarcoid, you diagnose them. Actually, most patients of sarcoid, we diagnose incidentally. You're doing CT for something else, you see biopsy, you see a node, you do biopsy, you see sarcoid, and most of them don't even need treatment. So sarcoid is more indolent than TB. That rash, David got it right, erythema nodosum. if you think of extra pulmonary manifestations of sarcoid, cutaneous manifestations are most common, and among them, erythema nodosum is a common one. So yes, also point to sarcoid than TB. Again, non-necrotizing or non-caseating granulomas, sarcoid more than TB, but also you can have non-caseating granulomas in TB, but usually TB is a caseating granuloma than non-caseating granuloma. And truly, the negative ZNPA staining also point to sarcoid than TB. And I didn't tell you this, but this patient was also seen by the dental guys, and they said they have to repeat both. They took again the tongue, and then they took the node. They sampled some node, they sent them to the biopsy, and then the results were similar. So the confidence that this was sarcoid was, I think, higher. So truly, as you're saying, very good. This was sarcoid, but I shouldn't take the credit. This patient came to me with a diagnosis at hand, and she was brought for me for treatment, and they said, okay, this shouldn't pass, I should present this. And to your surprise, the one who made this diagnosis is not even a physician, it's an ENT surgeon. So my friend, Thomas, I think he's here. If you want to talk, you can talk something. And yeah, but he not only ENT, he has some experience in internal medicine. I believe that's why he had diagnosis like this, diagnosed it. So the treatment, I kept this patient on pure prednisone 20 milligram OD. And I saw her, I think, after a month from I started the medication. There was no new node, or there was no node that were increasing in size, the existing ones. The tongue nodules didn't increase in size also, and the erythema nodosum disappeared. I think I will see the patient next week for the second time. And a few learning points because we're running out of time. So sarcoidosis is the multisystemic granulomatous disorder. The epidemiology is like that. The females are twice more likely to be affected than males. Blacks are more affected than other race. The age of onset of the disease between 20s to 60s. Etiology is still unknown, and the presentation is interesting because approximately half of the patients that have sarcoid were found incidentally, that they are doing imaging like chest X-ray for something else, and someone saw the nodes in the chest, and they biopsy them, and you find it's sarcoid. But thoracic lymph nodes involvement occurs in 90 to 95% of cases of sarcoid. If patients are asymptomatic and they have pulmonary symptoms, the symptoms will include cough, shortness of breath, fatigue, chest pain. But there are other extrapulmonary manifestations like on the skin, peripheral lymph nodes, like this patient had skin and peripheral lymph nodes, ophthalmological, cardiac, neuropathy, etc. The involvement of the mouth, the tongue, the nose is very rare, and it's a case reportable, by the way, which this case is on that pipeline. And in evaluation, so you do HRCT. We didn't do this in this patient because of financial issues. She's paying cash, and we had the biopsy already. We had the CT that shows part of the lungs, so we don't need. So what you see on the HRCT is perilymphatic nodules, bilateral hilar lymphadenopathy, consolidation, ground glass opacity, predominant in the upper zones, looking like TB, but it's not. So if you read cases, you see that they usually send what's called serum angiotensin converting enzymes. And I read that, yes, it's elevated in 75% of cases, but it has limited utility due to poor sensitivity and specificity. It has a 10% false positive. And those who wrote this topic on the up-to-date, they recommend against routine sending of the ACE, as you can diagnose patients who are not, that's the sarcoid. So the diagnosis, there is nothing that you can send to give you a diagnosis, but you have to have a compatible clinical and radiographic features. You have to exclude other diagnoses that will look like sarcoid, especially TB in this case, in this region that we are living. And when you have to see non-necrotizing granulomas on biopsy. So the treatment for a symptomatic patient and patient with mild disease, you don't treat them to self-resolve within 2 years. But if they have symptoms, you initiate prednisone at 20 milligram OD, and if there is response, you taper the prednisone. So yeah, that was the case today, and congratulations, David. That's a very, very good dissection of this case. Hope you have some reflection.
Thank you very much, Joseph, for the case. I'm exhausted. I've been going in circles over and over. It was a very tough case, and well, I think that underscores why we do this, because these are few patients, but as we've seen in these sessions, and maybe for those who are doing grand rounds and in clinical practice, there are some conditions that we consider to be rare or maybe non-existent in our settings, but they are coming up very rapidly. We are seeing a lot of autoimmune diseases. We've discussed about cases of SLE here. They are becoming very common. Cases of NMO, cases of MOGAD, and other things like those. So I think relatively there are very few patients, but then we need to prepare ourselves for the day we encounter these patients, because if we are not prepared, we'll miss the diagnosis, and these patients will be suffering multiple times, suffering from misdiagnosis and suffering from not knowing what is going on, what is wrong with their health. So uh, I thank very much everyone who's involved in the care of this patient, including Tom and Joseph, for preparing, because it has made us, it has added wisdom to us, because although we have not come across many cases of sarcoidosis in our routine clinical practice, but at least now we exposed second hand, and therefore when we encounter a case, I think our index of suspicion will be high. So thank you very much for the case and for jogging my mind today.
Yeah, thank you. I think we are at the top of the hour. If there is anything, Thomas, if you would like to speak, please welcome. If you have anything. Okay, it's okay if you don't. So I think I should wish you guys a good night and see you next week.
Good night. See you next weekend.